Trying to conceive and feeling overwhelmed and confused with unhelpful information and advice? This podcast is for you. Welcome to Don't Tell Me to Relax. I'm your host, Hannah Pern, a fertility acupuncturist and passionate advocate for better fertility education and support. Our aim is to empower you with information to support your fertility journey and provide a community for connection with people who get where you're at. If you'd like to join us or work with us in clinic in London or across the UK, all the information is in the show notes at the end. Hello, and welcome back to this week's show. Today, I am joined by the very lovely Lynne Chapman from LCRH Fertility Clinic. Lynne is a reproductive medicine consultant and has been working in the field for over 15 years. During that time, she has guided thousands of couples and families on their journey to conception with IVF, egg freezing, sperm and egg donor services. Today, we're going to be looking at IVF, but we're going to be looking at how can you optimize a cycle of IVF. And we're going to be exploring the fact that not all IVF is the same. And Lynne is going to give us her personal opinions and insights into how you can optimize your cycles and adapt your treatment to improve your fertility outcomes. So Lynne, welcome to the show. It is lovely to have you here today.
Hi there, Hannah. Thank you very much for having me today to chat. So I started my training in London as a doctor and then specialised in obstetrics and gynecology. So that's my basic. And then through that process of trying to help other people get pregnant or deliver babies or gynecological procedures, I went through my own personal journey of trying to get pregnant. I was really young in terms of today, potentially. I got married at 25 and started trying to get pregnant about 27. And so for the first 3 years of all of the kind of training in the world of pregnancy, I was not able to conceive. So that we look at some books of kind of people have written since, but I was always like, I am not P every month. I was not pregnant. I'm not pregnant. And that was quite tough in the obstetric world when you're struggling yourself. I then went through my own treatment process in an IVF clinic in London and was successful. So that's fantastic. But then had some of my own experience. And I know you can't empathize with people directly, but you can know a lot of the way that you felt in that journey, a lot of the struggles that you dealt with, and a lot of the medications are similar. So just the way that you took them, the way you had to worry about taking them, getting them on time, how you took them, they were all suddenly like, okay, I have a love and a gratitude for what happened to me. And actually, I'm sitting in the right profession to suddenly start subspecializing and go into the fertility journey myself more. So that's the beginning. And then I started obviously branching into the fertility world more and more over the last 15, 20 years, but with some degree of personal experience with me.
I was just looking at your bio previously before we came on, and you've worked at a lot of you've worked at a lot of the larger fertility clinics, and now you work on your own. Is that right?
Yeah, I'm one of the kind of 100% founder owned. I'm one of the very few, I think, in the UK that's not sort of a bigger, more corporate route of doing this. I started in London-based clinics, which were all very good in different ways. But what I realized when you work for a kind of larger clinic as a doctor, you have a timetable, and that timetable means that one day you might be doing an egg collection and another day you might be talking to a new patient. But when you start getting that bond with a new patient, my dream was to not hand over that procedure to a colleague or because you learn so much about that actual procedure that you might lose if you don't hand over all those facts. So my dream was I went from clinic to clinic to kind of try to understand why this success rate was so good in this clinic and what I was hearing was so cost effective and why it was so cost effective in this clinic. And I did go between about 4 or 5 of the top clinics in London just to kind of there was good working experience. It was a good time for my life, but I was kind of pulling together information. Then I just thought, well, I'm at a stage where I'd like to just take one patient on the journey that I would like for myself. So I took I thought, well, I'm just going to do this for the love of it, and see if this works or grows. So we had, for example, one patient who came and I scanned her. We do her blood tests. I was then the person to see that response to the medication at an egg collection, see what eggs look like, how many she got, how many I was expecting, and then take that on to an embryo transfer. And I believe that not only is it a very emotionally supportive thing for patients to have a few people, but very few, or one person in that journey, it's also so much more educational for the person trying to see where there might be failings in the process of the egg and the sperm becoming an embryo. If you're constantly in that process, looking from scans to endometrium to egg quality to how it fertilized, I think you see 50% more than you might see if you just jump on at a mid-cycle scan. So super valuable. I was lucky enough to have success, obviously with that patient, and through purely word of mouth of that kind of experience, LCRH has now grown considerably. And at the moment, it's more about patients telling their friends or their family member or their colleagues that this is the kind of thing that we're aiming to do. Obviously, not all cycles will fulfill or fit everybody's need. It doesn't fit all. Sometimes you're so simple in your ease to get pregnant. For example, maybe you have blocked fallopian tubes, and therefore if you had an offer of NHS treatment and you can wait a little bit of time to get on the list, you will be just as successful as you would be in my hands or anyone else like my hands. But when it's failed cycles in other clinics and you're trying to get answers, and most people nowadays have access to acupuncture to talk to and Google to go into a hole into, I think that's our advantage, is that we can then talk through every test result and question whether it was necessary to do the test in the first place, if it was value for money, or whether and what it meant to try and optimize going forward.
And when it comes to IVF, I think there is a belief before you go into the world of IVF that when you see IVF, you assume, or it's easy to assume, that all IVF is the same. And I think what people are often surprised at when they maybe move clinics or when they've been through different rounds, that there are many different approaches. And what we hear is there are lots of different opinions about what is the right approach for the right person. So so if we just talk about the beginning stage, so we're at the stimulation phase, when you've got somebody sitting in front of you, how do you decide what is going to be the optimal type of IVF for the person that you're working with?
I think you want to understand there's obvious big cohorts you're looking at. You're looking at kind of if they've ever done this before, and is there anything to learn from something that they've done before in another cycle, and not ignore facts that we have in front of us just because they're now in front of us and we think we do it really well. So looking back and seeing what we can learn from something before and improve on. Every cycle there are things such as low-cost IVF or mild IVF. To a degree, it's some degree of jargon associated with them, and that I would think in an ideal world, any patient coming through would want to kind of maximize but not overstimulate their chances, because privately it costs money, and therefore you don't want to be wasting that chance, because if you come through and you have very, very, very little stimulation, then you might get 1 or 2 eggs collected, whereas actually on your ovaries, when we look at your antral follicle count, your ovarian reserve, you might have 10 potential eggs that could have been collected. Now, from my point of view, if I'm not going to make you unwell by producing more, a sensible number of eggs to be collected, why not try and look at them all? Because I'm giving you what I'm trying to achieve in most patients, especially not people who've had failed cycles, but somebody simple who's coming for the first time, who's relatively young, so let's say 36 or younger, definitely. If we can optimize the woman to the right dose of medication and then look at the male factor fertility, with obviously you've got people we link with really closely, like Mr. Ramsey and Mr. Kelsey, to optimize the man, we can potentially do an IVF cycle once. And that's the aim. So if I can just stimulate somebody that we have one egg collection, and that, say, for example, in someone 36 or less, you might have 10 eggs collected. If we know everything about the sperm before they embark on that treatment, so either it's great semen analysis parameters, or they've been trying for over a year and they should consider adding on looking at the DNA fragmentation, or there's something about the normal forms on the sperm and actually the microbiome and low-grade infection should be investigated. The joy of looking, if we're thinking about a couple like this, a traditional couple, the joy of looking at the sperm in that view is that you can nearly, in 95% of men, take away a male factor on a day of egg collection. So in the past, we would do an IVF cycle and you would stimulate and then see how the one cell fertilizes and the 8 cells develop and the hundreds of cells become a blastocyst. And if it didn't do what was expected, think, oh, I wonder if there is a male factor here. Whereas nowadays, we don't need, hopefully, we've optimized that cycle so that each sperm that was selected for those 10 eggs is the best sperm that we could possibly have. And that means that you're more likely to reach this level of a blastocyst. So therefore, you're higher chance of outcome success than somebody who's not reaching a blastocyst on their first cycle. So you look at a woman's age, you look at a woman's BMI, you look at response before, you look at her current AMH level. Does she have very low AMH? And should we be keeping an eye on it, keeping an eye on her future family planning? I know I'm seeing someone therefore right that second, but if I have a 35-year-old with an AMH which is really low, meaning that her egg count is low, her number of follicles might be low, then it's all very well for me to try and help get her pregnant in one cycle. And if she's 35 or less, if I can create an embryo that reaches a blastocyst, she will have about a 50% chance that that embryo is genetically, chromosomally normal. If we genetically test it, which we may come on to, then she would have a 70% chance that that will go on to be an ongoing pregnancy. If I just think that about the couple, then I'm not thinking, well, in their dream world now, are they thinking about having one child? Was their dream 2 children, but then they got a bit stuck in the fertility world and now 1 child would be great. But if I know that actually their dream is to create 2 children, then I also need to know that 1 blastocyst that I've just created may not be enough in that circumstance in order to help their overall dream of family planning. Now, obviously, I can't promise their dream of family planning, but I can aim to help achieve their dream of family planning by understanding them in more detail and their kind of larger host.
Yes. And Lynne, can I ask, just to go back, because you were talking about DNA fragmentation and more male investigations, because it's something that we see a lot with people in different clinics where they're told, oh, you don't need to do a DNA fragmentation. We still hear this information being given a lot to people, and people then feel very confused because they're told it's a waste of time, the treatment would be the same, we would just do ICSI anyway. So people often don't do DNA fragmentations or further investigations into the men because that's what they've been told. So, you know, for anyone listening to this, how do you decide whether it is actually worth doing further investigations into the male side of things? Because it does feel like it's very different depending on who you're sitting in front of.
I totally agree. I also think it's totally relevant of first 3 things, I suppose, whether the couple come into this with a history of trying for a bit of time. Otherwise, it's probably a waste of money. So there's just doing the test for it, I always feel is not a valuable tool. But if you've been trying for over a year, then potentially the sperm might be a little bit weaker. And therefore, the ability to create an embryo from 1 cell to hundreds of cells, it has to be very dynamic, the sperm. And so we need to check if it's been a year of negative pregnancy tests or biochemical pregnancies or early miscarriages, whether actually this sperm is a bit more fragile. So if a patient has had over a year of trying unsuccessfully ongoing pregnancy or repetitive miscarriages, I would think it would be relevant to consider. But then it comes into the next layer of, well, why do it if the clinic that you're at won't change their plan for it? Well, then, no, I don't think so helpful. But then you could go one of two ways. You could go and see if it came back that the semen analysis was maybe abnormal, the DNA fragmentation was high, then often that could be because a man has a varicocele, so heat going to the testicles. It could be because of a way of life where they cycle or they horse ride or they like saunas or baths. All these things cause more heat to the testicles, or smoking and other lifestyle things. So they could, with us, just have a look at that without taking any extra kind of expensive male lead tests. Or they could then still know that their current clinic not very interested in DNA fragmentation, but if they see somebody like Mr. Ramsey or Mr. Kelsey, they will optimize, because if you have a varicocele, you can treat it. If you have a low-grade infection, like which is causing the DNA to be weaker, you can treat it. And then you could enter your clinic that doesn't necessarily believe, but you might have simply by lifestyle lowered your DNA fragmentation so that IV or ICSI would be okay. I know this sounds long-winded, but the third approach is more of a clinic like ours, which is worth doing the test because we would also potentially look differently at the sperm on the day of an egg collection. So if the sperm was normal semen analysis, which is literally just a quick snapshot of sperm, so useful to have, but it doesn't tell us about the integrity. It's like, for me, it's like telling you about the heart or the lungs or something of us, that if I just take a picture of you, the outside, I have no idea. Whereas the DNA is looking about the mechanism of action. So if you had a normal semen analysis and you never did a DNA fragmentation test, in the lab on the day of an egg collection, the man would do a sample and IVF would be chosen. Now, if IVF is chosen, obviously you have 1 million or so sperm dotted around each egg. And again, natural selection will occur of fertilization. And if that sperm was the weak one, it won't have the journey outcome that we want it to. It won't go from the cell divisions to the rapid cell divisions that we want it to have. So therefore, in the lab, number one is you would look at ICSI, but you wouldn't look at ICSI just by you picking a sperm and putting it in. You would be looking under the high-powered microscope for certain features that embryologists can see if that sperm was going to be a bit more fragile. So the embryologist would be told, this sperm is high DNA fragmentation. Can you look for these certain characteristics and features to choose that best sperm? Lastly, we obviously have this zymote test nowadays. So some men in preparation in our clinic would find out that they have a high DNA fragmentation test. And then they will do a test run to see if this zymote, it's like an obstacle course, pre-selection tool, if the sperm goes through that zymote and comes out with being a better, so it basically rules out all the weak sperm, and the other side of this obstacle course, you have the stronger sperm. Then currently, we would still pre-select the sperm by ICSI, so look under the microscope, but we've had a kind of a filtration, a selection method ahead of actually the day. So yes, there's no point in necessarily doing a test if you can't then help it. But in 70% of men, if we've analysed that they have more fragile sperm, they've tried lifestyle, it's still more fragile, then they will try the zymote. Maybe this selection tool will make it stronger. The zymote in 70% of men does make it better and the stronger selection, but in 30% it doesn't. So I also wouldn't choose a clinic necessarily that just automatically is like, we have this wonder tool, it's the zymote, because in a certain proportion of men, especially if you speak to the male urologist, the sperm is actually worse the other side. So in which case you've come to see us with all this optimism and us kind of promising many things, and actually we do something just by running it through the zymote that could be causing your cycle to not go so well. So this is the reason in our clinic we do a prep run. Yes, it's more expensive on the outside, but at least we know that this tool will work. So if this tool pre-selects, then, as I said right at the beginning, you're almost getting to the stage with the help of lifestyle support, antibiotics, zymotes. You're nearly able, because sperm is 16 million, 50 million, to choose 10 top ones under the microscope in the majority of men, in which case then you are left with egg age, egg quality, and letting us see what the egg factor is going to do, because we've so well selected the zymote machine at the beginning and the DNA and ruled out all those things. However, what I worry about is people just doing lots of tests unnecessarily. One, when you're in the fertility world, you obviously become keen to optimize. You take on a lot of responsibility yourself. You try to answer all your own questions because you're not maybe getting the answers easily. And therefore, you may end up doing, without needing to, because there isn't a male factor, for example, a semen analysis, a DNA fragmentation, a microbiome test. And actually, this is thousands of pounds that may not need to have been spent. So I had somebody the other day, which just alarmed me slightly, who maybe had a semen analysis in 2015 and then had been trying since. And their new test for me was a DNA fragmentation test. Now, that's all very well, but that's like jumping from A to Z. I just needed at the chat a semen analysis, because if it had been that they hadn't been trying for longer than a year again and the semen analysis was perfect, it's not relevant at that moment in time. So I know that people want to be super proactive, but if you can go down the wrong route and you can start taking the wrong amount of antioxidants because there's an imbalance. A small level of an antioxidant may be a good thing, and it's got vitamin C and vitamin E and selenium. But if you've got 6 jars full next to the kettle, it actually may be causing an imbalance of too many good bacteria, too many sort of good antioxidants. And actually that means that we can't fight a bad infection when it comes. So sometimes being so proactive is detrimental. And therefore, I would see an expert who can take you through the required steps. Again, a microbiome might be relevant, which might come on to kind of optimizing patient clinics and why people look at certain things and why small clinics might see things differently. But a male microbiome might be done if a man has a low semen analysis normal forms. So the normal forms may be less than 4%. Or the pH in that sample might be raised. Or there might be other cells seen, like white cells seen at the same time by a good person looking under the microscope. All indications to do a microbiome test. But without them, there probably isn't an indication to do a microbiome test. And the same for a female microbiome test. We get that sort of sent to us more and more and more. And it comes with lots of alarming, because again, we have natural bacteria and it doesn't need to be alarmist. But if you just do the test and then you're trying to read it and understand it yourself, I think it sends more stress levels and, more anxiety and back down a Google search again. Whereas for me, the female microbiome, and when I speak to my sort of male urology colleagues as well, it is relevant if you have something like bacterial vaginosis or something that's causing you symptoms, which you would be aware of. But the majority of the benefit of understanding a female microbiome is because it's more linked to the sperm pattern. So it's probably something that could be shared, that could be picked up by one test rather than another test. But it's unlikely, I would suggest, that it's the overall cause for a female aspect side of fertility. Them not to be ongoingly pregnant. We look at things like the Emma and the Alice test, which look at the endometrium and see whether somebody has a chronic endometritis, which is a chronic infection in the lining of the womb. They're more likely to have that if they've had surgery to the womb, a delayed miscarriage. And without that, they probably don't have a chronic endometritis. But obviously, if they did have one, antibiotics and treatment could make them pregnant. So it's just optimizing which tests you might actually need. And I'm hoping to do more studies and confirm, but the vaginal microbiome, very, very useful. But at the moment, it's not a surrogate marker for the endometrium. And the Alice and the Emma test at the moment are the way to check what is happening in the lining of the womb, the endometrium. And they are, with us, done if we have an embryo that is maybe genetically normal and has not worked. So somebody who's transferred back a top quality embryo, which has been genetically normal with a 70% chance that it should go on and be an ongoing pregnancy. If we're getting to that statistic and somebody is not pregnant, looking and evaluating the lining of the womb and making sure that the levels of good bacteria are good and the levels of infection are not present will optimize to a small degree that next transfer success.
What do you think about the menstrual blood tests for endometrial?
We're looking at it. So a good thing to start looking at more and more, because my goodness, how nice it is not to be taking an Emma analysis test. So an Emma analysis test for us, you come in a slightly full bladder. It's like a smear test, and a small catheter passes through the neck of the womb, and for 10 seconds, hopefully with us, it will feel uncomfortable, and the sample goes off and it takes 2 or 3 weeks to come back. And we know that that's endometrium from the right time of the month, and we have a diagnostic value. At the moment, the menstrual blood loss test as well is being a surrogate for that. And I think we go to global meetings at least 3 or 4 times a year. And at the moment, the data is so small on even the Emma and the Alice, and definitely the menstrual blood flow, to be saying that it's absolutely dynamic data that is 100% the surrogate of the endometrium test. So at the moment, it's all useful information, but again, it hasn't got enough evidence to back it for me to say, well, that's the definitive answer to the problem.
And is there any other additional testing? Because like you say, there's so much out there. Is there anything else that you think does have value in terms of optimizing IVF and IVF outcomes?
Yes, we are a strong believer in discussing our patients PGTA, which is genetic testing of the embryos. We often see patients who have come from previous clinics or failed cycles, so they're very knowledgeable, but maybe they haven't had that testing done. It's got so many positives to it, and some obviously costings in the private sector, negatives to it, with the fact obviously that the HFEA have red lighted it to a degree or green lighted it into a separate kind of response. It's interesting in that it will help diagnose whether an embryo is genetically normal, but even not all the testing companies that do this are the same quality. So we link to the lead genetic testing company called Juno Genetics, and their data is very, very strong. And you know what you're getting when you test an embryo, and you know how it's being tested, and you know what that result physically means. The interesting fact about kind of why PGTA has documented as being red with the HFEA is that it says it will not get a patient more pregnant than if you had all of those embryos that you might have collected put back one at a time. And that's absolutely true. However, if you take into consideration that grading of an embryo makes no difference to whether it's going to be genetically viable, so you could have an AA, an AB, CC, and that does not mean that it's going to be more genetically normal. So therefore, how is an embryologist selecting if you have 4 embryos and you're 35? How is an embryologist selecting which one to put back first? It's done by grading, which is not in any way related to whether it's genetically normal or not. So it could be that the first embryo goes back untested and it was the right embryo. Well, that's why PGTA did not help in that couple. But it could have been that the first embryo went back, we didn't know, but it was the abnormal embryo, it did not work. Then either they have a miscarriage, which would be like it's emotionally, physically traumatic, or a negative pregnancy test and they can crack on with that second embryo. Again, if that second embryo is genetically abnormal, but you did not know, it will not succeed. And then finally, you get back to maybe the third embryo, which was the genetically normal embryo, and you have an ongoing pregnancy. Now, months have gone past, medication cycles have gone past, emotions have gone past. So it definitely has a benefit to think about it. Now, it won't make you more pregnant. If you are 42, you have a 92% chance that that embryo is going to be genetically abnormal. So if both of them that get created are genetically abnormal, PGTA wouldn't have helped you in an ongoing pregnancy. You could have just put them both back. They wouldn't have worked. You could have tested them. They would both be abnormal. My reasoning for still considering testing them at 42, if you've got a 92% chance of them being abnormal, is we're trying to find the needle in the haystack. We're trying to diagnose why you should consider continuing with your own eggs. Can we find the genetically normal egg? And this is egg-related, how the chromosomes divide to create this problem. Then we have a very high chance of success with women in our clinic who are over 40, but less than 45 ideally, because we're looking for that one genetically normal embryo before we do any transfer. And if we therefore find it in that patient cohort and understand that it's not necessarily easy to get a genetically normal embryo, we have high chance, a 60 to 70% chance of this going on to be a live birth. And that is why we have a very high success rate with women over 40, but it's because we are trying to find the genetically normal embryo before we do a single transfer. My other thought about it is if you're 35, you have, why would you PGTA that embryo? Well, at 35, it's a 50% chance it's genetically normal, viable, and therefore all other factors being real, just a slightly less than a 50% chance if you didn't test the embryo that you would have an ongoing pregnancy. If you knew it was normal, even for a 35-year-old, you would have a 70% chance that this is now going to be an ongoing pregnancy. So that, for some people who've had failed cycles, still worth it. We generally would ideally choose to do a fresh transfer in a young woman where the chance of that embryo is more than 50% chance of being genetically normal. Why test it? Why do anything? Just put it back. And it has a high chance of being good. That probably wasn't your factor of why it wasn't working as a couple. And therefore, hopefully, very high success of it working. However, then if you're lucky and you're a young couple, you have 4 more embryos in the freezer again, or even more if you're got very high antral follicle count and egg count. So you say you have 4 more in the freezer and you think, well, I'd love a second child. And this is great. I have 4 embryos in the freezer. And genetically, you don't know. You haven't tested them. You're giving yourself false hope that there is something there that's going to give you a chance of success. And you're paying for storage of embryos that could be so abnormal that they will result only in a negative pregnancy test. So therefore, it's worth considering testing embryos that are in the freezer. One, because it gives you much more information about your own eggs and your own egg journey, but also it gives you much more of a stable plan if you do want to come back for a future child and you know what's stored. Bigger picture, we're storing embryos all over the world that are probably a large proportion of them never viable. If we are testing them, we are saving that capacity, that financial issue, the storage capacity of embryos that are not genetically going to ever result in an ongoing pregnancy. So that's a bigger kind of governmental thinking, all really important things to consider of why at least thinking about genetically testing in some circumstances. Some patients will ask me, well, I've only got one and why would I genetically test it? Will it not harm the embryo? Now, if it's done in a lab, so we work with labs in central London that do genetic testing all day, they're very, very adept at it. And in which case they won't do genetic testing if they think the embryo wouldn't survive the testing. A strong embryo that survives the testing is already as robust as it should be to carry on to have an ongoing viable pregnancy. We get to situations that maybe somebody's had an embryo frozen in another clinic and that embryo is transferred, it's then defrosted and can be genetically tested to see if it's viable for a transfer. Sometimes you get a result which is a no result, and that embryo then needs to be offered to be retested. Now, an embryo that can go through that defrosting and freezing process twice is a very robust embryo. And on top of that, if we have a euploid result, we have the same success rate as if you're going to have put it back, 70% chance. So really robust embryos, they are so delicate and so tiny, but if they're going to go and be an ongoing pregnancy, they need to have this level of robustness, we think, in order to do the rest of their journey of cell divisions.
And so what about this idea that when people have genetically tested embryos, that what we see a lot these days is people want to do then lots and lots of tests like the Emma and the Alice. Maybe they want to do the immunology profiling. People want to sort of do everything they possibly can to make sure the environment is the best it can possibly be before the embryo is transferred back in. How do people make a decision about what they should or shouldn't do in terms of, the level of tests? I know we've spoken about microbiome and the Emma and the Alice, but what about all the immunology that is out there?
It's interesting. I would say where we look at it is don't overcomplicate and don't do too many tests that you just don't need because, well, a lot of it is a waste of money and a lot of stress when you're getting results back. And there has to be, it's not a one size fits all. It's not a throw every single cent of money you could possibly find at it and it will all be okay. It's more of I like to think, don't know if anyone's ever watched a House, like House MD. I mean, he's a bit mad. But the whole concept should be very, very tailored to what we're seeing. So obviously, if you've got a thin endometrium or a polyp or a fibroid in the lining of the womb and you've got a genetically normal embryo in the freezer, you must remove those things and optimize the lining. If you've got vaginal discharge or anything in your story that's looking like there might be a problem with the infection, definitely do the testing. But the majority of patients come to us, their lining of the womb has looked lovely throughout the stimulation. They have no background history that there should be low levels of infection. They don't have any history in their family history, for example, that may link to thrombophilia testing and blood clotting testing, in which case we really have, it really kind of, if you put an embryo back and it is genetically normal, it has a 70% chance, which I think most people would say, that's fantastic.
Mm.
So if that hasn't worked, I had a colleague in the States who was saying, well, in the States, they're very big genetic testers. And so they almost don't see a patient after like one genetically abnormal embryo. If it doesn't work, they don't come back to see their reproductive doctor again until a second embryo has failed, because the chances of two working when they're genetically normal is so high. By 3, we're talking 95% without doing any extra testing. So my theory is if we do one embryo based on history being very straightforward, we've now got this gorgeous, lovely, genetically normal embryo. It has a high chance of working. Don't start doing the other tests. Put it back and give it a shot. And we have a very high pregnancy rate. If you fall into my pregnancy category that did not work on the first embryo transfer, then we need to do a little bit more investigation. So then sometimes we'll ask the GP, will they look at the thrombophilia screen for us, the blood clotting screen? Is there anything in the family history? Should we be considering aspirin or giving Clexane as a blood thinner? Do we have any evidence to kind of base why we should do that? Then is there anything in the lining of the room? The ERA test of like which particular hour this should go back was evidence-based, lots of information for it. And then the more people have done the test, potentially at slightly inaccurate times, the data is more generically grey on whether the ERA test is as evidence-based as I would like it to if we were going to do it on a regular basis. But it does look at the window of receptivity, and some degree of common sense would be that, well, is that a factor in people's lives? Because naturally this egg is released and then it comes up the fallopian tube and it's 8 cells, and then 2-3 days later it's in the lining of the womb. That is why we base our 5-day transfer on. And obviously some people, this could be much faster and their lining of their womb could be more receptive day 4. It could be really slow up the fallopian tube naturally. And so maybe they've had a biochemical result naturally. They come into IVF and they start having negative pregnancy tests. And it should be, well, why is that happening? And is it because we are making them generic globally, 120 hours of progesterone day 5, and actually they would be better day 6. So there is some common sense to it, but it would be at the stage that someone's having repetitive euploid embryo failures in order to balance the statistical evidence and the reason for that cost of that test to look at it. And the same comes with the EMA and the ALICE test. If there's no success with this embryo and you're getting high levels of all other patients would be pregnant at this stage, it's worth having a look just to make sure that the lining of the womb is absolutely as perfect as you would think. I don't think there's enough evidence on the immunes, and I suppose I get worried by it. It goes in cycles. So 15 years or so ago, we were in global conferences and there was Ashley Moffat, who's very well known in one side and has great papers on suggesting not to do lots of immune testing and taking lots of the medications that people could do, versus other lead consultants who were very, very pro. In our global meetings, it almost vanished because people were realizing that there was no evidence to natural killer cells, and some of the medication that patients were being prescribed has serious harmful potential consequences. Obviously, many successful pregnancies and no harm. But if you look at the data, you need strong evidence to say that this is really a very useful medication for an outcome. And therefore, you need the outcome to be that there is really a problem that we've analysed statistically and said that this is doing harm. And things like natural killer cells are, from my understanding, needed in the endometrium. So the high levels that you can pick up from them does not necessarily need to be a bad thing. We need implantation of an embryo to occur. So I'm not sure that there's no immune factor. That would be crazy. But I am quite convinced that the research and the evidence is not there for the things that people are potentially treating at the moment. And so my strongest theory is do no harm, unless we do no harm ever, but look for the evidence in the first place before you start even trying to then see what medication might fit that. And I think with our success rates in our clinic, they are so high. And if you had a patient who'd had, even globally, this isn't just our clinic, but there's stats out there that if you have 4 genetically normal embryos transferred, you have over 95% chance that that couple will have an ongoing pregnancy. That is without adding in any of those things we've talked about. No ALIS, no EMA, no thrombophilia, no immune testing, just getting the right embryo with the right mechanics. So I think what we need to be careful of, I suppose, is a big point, is do the patient no emotional and financial or actual medical harm in order to get to the outcome that we all want to get to.
So I guess what I'm hearing is it's the genetics of those embryos are the biggest key factor in IVF outcomes. And I guess that going back to that, then that goes into the whole idea around, this idea of improving, it's very difficult, isn't it, in terms of like egg quality? How do what can we do about egg quality? It's a big debate. But when it comes to sperm quality, it seems that there are a lot of things that we can do and we can measure and we can study it and see that it's had a positive impact, whatever we've done, so that can really help form the best possible embryos to then go on and be genetically tested, to then be transferred, seems to be the way of optimizing IVF.
Absolutely. Because the sperm, it works because of the biology of us. So the sperm have a 3-month turnover. So we are able to action if a man is sick, if a man has had a big night out, all those things will affect that 3-month turnover. Whereas a woman has had her eggs with her since she was in utero. So since she was born, and the number, as we all know, but we hear again, just declines. At 30, we have that number of eggs, and it's like, explain it like an onion. We have the surface, the follicles that we see are the surface of that onion. And then the next month, it's the next layer underneath that layer. And that is what we have. So as an IVF doctor, that is all I get to look at. I get to look at, what have you got this month? Maybe the next month, if you try naturally, that one amazingly gorgeous normal egg would have come naturally. My chance is this month, and you have these follicles there. And if I try and make them grow, I try and see what eggs you've got, and I know how to optimize the sperm to the best I can. I'm giving all of those the best shot to see if they are genetically viable. And it's because the chromosomes of the egg, they start at 46 chromosomes, they just have to divide. So the egg has to go through a last cell division that's pulling apart. That's, if you can think of oil, in your 20s, that last cell division happens really easily, and 23 chromosomes glide off and potentially meet the male 23 chromosomes, and you have a lovely 46 chromosome embryo, genetically normal. That's why in your 20s, it's such a low chance that it is an abnormal embryo. But at 35, it's a little bit more stark. And at 40, it's even more stark. And at 45, again, you've probably got a less than 1% chance that you'll find a genetically normal embryo, which is, again, some of our patients move on to egg donation if they're not having genetically normal embryos form. And you can then see that we're not getting a normal embryo. And it might be that insight that's moving them forward to saying, okay, I've really tried with my own eggs, but I'm not finding a genetically normal embryo. And therefore, what do I do next? Do I try again, or do I move to egg donation? And we then see through that cohort of patients that they then go from having had years of a struggle to a 75-80% chance of a pregnancy in the first time that they put an embryo back. It's strongly linked to, obviously, the egg being the genetic normality factor. And unfortunately, even if the sperm sample in that is a little bit worse because the man is a bit older too, a young egg can do some magic with it, whereas the slightly older egg needed, it was incapable of kind of pulling the sperm along and optimizing it. So that's where I think that it's a large portion is we can so optimize the male side and give each egg for that age of woman an optimal chance of being whatever its journey is going to be.
Yeah. And so, Lynne, before we finish, one last question, because we get asked this all the time. From the female side of things, in terms of optimizing their egg quality, a lot of it is obviously down to genetics. We have no control over genetics. We're born with those genetics. So is there anything that you can say to people try this, or this could help, or how you can improve your IVF outcomes in terms of like patient control, things that they can do themselves?
I do get answered this question the entire time. It's so hard to answer because there's so many books and so many thoughts on it. My simple answer is there isn't very much you can do. By the time that you come to see us, there may be some events that have already occurred to you. They might be like you have a family history of endometriosis, you personally have endometriosis, and that's just been a life event that's slowly built up over the time that you come to see me. It could be that your family history is of premature ovarian failure and you found out that your mother, you mentioned it last month, that she had a slightly earlier menopause. So all of these things have been heading towards your time of when you come and see me. It could be that there was a long history of smoking. Now you stopped smoking, and did that have any impact? Probably not so much, but worth bearing in mind and try and stop smoking a little bit earlier. But the things that you can now do, they did studies to obviously talk about antioxidants and a healthy diet and the Mediterranean diet. All of these things are fantastic. And all of these things, even like something like CoQ10, some antioxidant that can potentially just help with the kind of the last cell division, like the oil in the egg, to see if we can try and make it slightly better. But I would say that with a little bit of caution, in that there's not many things out there that are truly going to change what the nature of that egg was that month. And I think caution for women trying to panic and go shopping and spending again a lot on supplements, because truly, if I could see somebody in March, as opposed to say, go away and take lots of supplements for 6 months, your AMH declines by 0.6 every month, your fertility profile. So I'm losing the ability to find that normal egg while supplements are being added on. And I suppose I worry about that a little bit. There's people trying to look at things about stem cell injections, people who have really serious, like premature ovarian failure. But they found that it's quite beneficial, and it may be beneficial. There is some evidence if somebody is less than 35, 36, but over 36 is the majority of the time that people are wanting to have help with their egg quality. And they cancelled or postponed any further research on it because it was not showing to have any advantage to a near 40 egg to do all this kind of extra treatment. There's things like PRP, which might be out there. At the moment, again, the evidence is not strong, but it's also not a hugely expensive or hugely difficult procedure. So I imagine that over the next few years, evidence will come of whether something that is of any value or not. At the moment, it is not showing any evidence. For the ovary, it might be something that's maybe showing a little bit of evidence towards helping thicken endometrium ahead of an embryo transfer. So I think, again, we become very keen to work it out ourselves and start diverting into all sorts of things. I would say healthy life with a moderation of fun should be the answer.
Good one. Oh, Lynne, thank you so much for your time. It's been so good to speak to you and have you on the podcast, because I know that will be so helpful for people to hear. And I know, because we see many people in your clinic, that you do have really amazing patient care and you get really good results. And I think the way that you go about your IVF really obviously contributes to that. So it's great to listen to you speak about why you decide to do things that you do. It's really interesting. So thank you for your time.
Thank you very, very much for having me. I love my team and my work, and I think it just shows as you turn up and each day. It's so enjoyable.
Thank you, Lynne. I'll put all your details at the end of the podcast as well, so everyone can find out more about you.
Thank you so much indeed. Take care.
We hope you have found this helpful. If you'd like more on fertility education, please see our Teaching to Conceive free course linked at the end of the show. You'll also find the link to join our community. For more personalised fertility support, you can work with us one-to-one in clinic and online. You can book a discovery call to find out more.